to lose my voice too a little bit. It always happens during the first couple weeks of the quarter. It's like talking way too much. My voice is not used to it. Okay, so the next thing I want to just talk very briefly about, I think this was like chapter module 3 in your textbook, and I'm really being brief with this, so if you want more information, you can, read the chapter if you haven't already. So we're going to talk a little bit about kind of the methods in general of assessment and diagnosis. So first we're going to talk about some kind of testing concepts, so concepts that have to do with how to develop different inventories. So you all hopefully had a chance to look at the depression and the anxiety inventory that I posted on Canvas. So that gave you kind of a little taste of what I'm talking about when I say something like an inventory or a test. That's what I'm talking about. So we'll talk about some issues that are concerned with that, things like reliability and validity and standardization. If you have no idea what those words mean, don't worry, because you'll know by the end of this short lecture. And then we'll talk a little bit about kind of the general approach to making an actual official diagnosis in like a therapy setting, which is almost always, at least in the US, going to utilize what's called the Diagnostic and Statistic Manual, or the DSM. There are lots of different versions of the DSM. It basically gets updated every few years. At this point, we're on the DSM-5. We're technically on one that's called the DSM-5 TR, which the TR just stands for text revision. The one that I have in my office is just the regular 5, so it's not the most up-to-date one. I'll kind of talk about what some of that means in just a minute. So first, let's talk a little bit about some of the methods that are often used to assess a particular disorder. And this is kind of like from the beginning, the conception of trying to even decide if something should be labeled as a disorder or not, all the way up through like actually diagnosing that disorder in a patient that walks into a clinic or into a therapy setting. So these methods are used kind of throughout that entire process. So one of the most common methods that's used that really would be kind of strung throughout all these other methods as well is just observation. So observing the way that a patient talks, the way that, sort of their physical mannerisms, observing their behaviors, their, emotional control, etc. All of that would kind of persist throughout all of these other methods as well. But observation is always very important, being observant of things that might not necessarily be obvious. Very subtle things can sometimes also be symptoms of disorders or kind of like flags that someone might have a disorder. Clinical interviews are another very common method. So, as the name implies, that's basically interviewing the patient, trying to get information about their history, their symptoms, how the symptoms are affecting their day-to-day life, their school, their work, their relationships, etc. Then there are the various tests and inventories. So again, that kind of goes back to the depression and anxiety inventory. We have inventories for a lot of different, disorders, different personality factors, etc. Kind of like we talked about last time, just remember that those tests and inventories can never be used alone to make a diagnosis. So I hope that's something you kind of noticed. Like if I gave all of you that depression inventory that you took or that you saw on Canvas, if I actually handed that out and had you fill it out, do you feel like that would be an accurate reflection of if you actually have clinical depression or not? Like just that test alone. Probably not going to be enough, right? Almost never is going to be enough to tell. But again, they're useful for like research purposes. If I want to, assess 1,000 participants and try to get, what level of depressive symptoms do they have? Does that correlate with something else? Then those inventories can be really useful. They can also be useful just as kind of a starting place. So a test or an inventory might be included in the initial clinical interview. So if a patient or client walks into a therapist's office and they say, I'm feeling depressed, I'm feeling anxious, and I want to work through that, then the therapist might give them one of those tests or inventories just to kind of see like where they're scoring at the beginning, and then use that, maybe even give it to them multiple times throughout, their therapy journey to try to see if those symptoms are improving. But those tests and inventories alone can never determine a diagnosis. Neuroimaging is another method that's often used, so trying to see if are there, abnormal brain structures, is some part of the brain too big or too small. Also looking at activity in the brain, is a particular area of the brain underactive or overactive. that can often be very useful in diagnosing a disorder. Physical examinations can also sometimes be important, so trying to figure out, is this something, in the psychological realm? Is this something more like a medical issue that should be dealt with medically? So, like for example, if someone is suffering from diabetes that's not diagnosed, then they might have symptoms that look like depression. They might feel, they might have really low energy, they might have a hard time getting motivated, but instead of it actually being depression, it might just be undiagnosed diabetes that needs to be addressed and taken care of. And if they get the proper medication for that, then those depressive symptoms might completely disappear. So something like a physical examination might, help with assessing. Behavioral assessments. So behavioral assessments could be also kind of like tests where you're basically having someone do some kind of task, but they're usually going to be more cognitive in nature. So maybe, there's some disorders where someone might have like working memory issues, for example. So maybe I have someone do some sort of memory test to see if that's a potential symptom for their disorder. But behavior could also be something more observable, like can they regulate their emotions, for example? Are they like throwing tantrums, or are they able to control their behavior? And then I guess cognitive intelligence tests, I kind of already talked about that with behavioral assessments. Some of these sort of overlap a little bit. But so again, that would be things like, testing someone's IQ, testing their memory ability, testing their language abilities to try to see if those are any potential symptoms that need to be taken into account whenever we're making a diagnosis. All right, with all of these different types of assessment, but particularly with the inventories, like the depression and the anxiety inventory, there are a few things that always need to be kind of constantly tested and reported on, just to make sure that those tests are doing what they are supposed to be doing. So one thing that we want to look at with all those inventories is what's called reliability. Reliability is basically a test's likelihood that the results will be repeated under the same conditions. So if I have 20 people who are all actually clinically depressed, then that depression inventory should reliably measure that depression. All of those people who have clinical depression should get a score that reflects that depression. If they don't, if their scores are wildly all over the place, some of them have a high score, some of them have a low score, then that means that that test is not reliable, and it's probably not a very good test to use to try to assess someone's symptoms. So reliability is how likely that the test will repeat the results under the same conditions. Validity is basically to what extent the test is actually measuring what it's supposed to be measuring. And there's lots of different ways to test validity. One of them is what's just called face validity, like basically does the test make sense? So, I could pull up that inventory on depression, but if you look at all the items on it, it's asking things about like mood or, things that have to do with depression. So face validity would say, that scale probably is asking about depression. I'm trying to think if there's anything else I want to say about that. So validity is basically, is it measuring what it's supposed to be measuring, essentially? Which maybe sounds kind of silly, but if you think about, in psychology, we're often dealing with concepts that are maybe a little bit abstract. It's not something that we can observe directly, like a chemist or a physicist or a biologist, can kind of directly observe their samples that they're working with or whatever. When we're talking about psychological concepts, things like mood, that's not something you can necessarily just observe. It's something you have to measure in kind of an abstract way. And so we want to make sure that our inventories and tests are actually measuring what we think they're measuring. Standardization is basically the process of trying to determine what is normal and what is abnormal. So usually if you have an inventory like the ones I showed you, the depression inventory or the anxiety inventory, those are typically going to be given to a very large population that ideally has a lot of variability. You have some people who are depressed, some who are not at all, some who are maybe a little bit or borderline, and then you basically use the scores from that large population to try to figure out what is normal and what is abnormal. So you're going to find, what's like the average. Maybe the average score is somewhere in the middle. I don't remember the scores on that inventory that we looked at. Let's say it's like 0 to 30, just as an example. So 30 is the high end. If you score a 30 on the depression inventory, that means you have like the most severe depression. 0 would mean you have no depressive symptoms at all, right? And when we're standardizing, if you give that test to 1,000 random people, probably the average is going to be like 15, like somewhere around there. You know, most people are going to score kind of in the middle, and you're going to have a distribution where lots of people maybe score kind of that average. You have some people that score really high, some that score really low. So using those scores, you can kind of figure out like what's quote unquote normal, what's the cutoff score that we're going to say is, you know, high enough to be considered depressive or depression symptoms or whatever. So standardization is just that process of trying to figure out what a quote unquote normal score would be. All right, so when we're diagnosing abnormal behavior, we use a lot of those different methods I just talked about. Hopefully the methods that we're using are all reliable and valid, and they have some kind of standardization so we can make statements about what's normal and what's abnormal. And then all that information is kind of filtered through the DSM, or the Diagnostic Statistic Manual. So, like I said, DSM-5 TR is the most recent one. Basically, every version of the DSM, there's, you know, sort of a council of people that put that together, that meet regularly to try to make decisions about what should be included, what should be excluded, should we be changing certain language to kind of be more up to date with the times, things like that. So, for example, one of the true or false statements that you had to do with like sexual identity and whether that's a disorder or not. It used to be considered a disorder in, I think even the DSM-4 actually had like some gender issues in there that were considered psychological disorders. And the DSM-5 basically either took those out or kind of rephrased it in a way that's different from what the DSM-4 said. In the past, some previous DSMs, like maybe 3 and previously, had homosexuality as a disorder in there. So certain things like that get kind of removed or added as we get more information that kind of, you know, contradicts what the DSM might have said previously. So that's why there's all these different versions. I believe whenever there's the TR or text revision, that basically means that it's very minor updates that have happened. So that's why I haven't purchased the newer one yet. They can be very expensive, so I'll wait until the DSM-6 comes out to spend the money to get it. But basically what the DSM does is it describes the different criteria for all the psychological disorders. So it has them broken up into all these different categories. So there's like mood disorders, for example, we'll talk about next time. So that would include things like depression, bipolar disorder. And then for each of those disorders, it lists out lots of categories of symptoms. So with depression, you will have things to do with mood, obviously. But you might also have some behavioral symptoms, like your sleep changes and your eating habits change. You might have some cognitive symptoms. So some people with depression might have like brain fog, basically, where they can't think clearly or their memory might suffer. So there's all these different categories of symptoms for a particular disorder. And usually the DSM will say something like you have to have 4 symptoms spread across these different categories, and they have to persist for some amount of time. They have to persist for 2 weeks or 4 weeks or whatever it is, depending on the disorder. So the DSM will basically lay all that out. Like, these are the criteria that a patient has to meet in order to be clinically diagnosed with this disorder. I'm trying to think if there's anything else I want to say about that. So as a therapist, you know, your patient comes in, you're basically kind of checking off boxes to see if they meet all those different symptoms, and again, kind of asking questions to get at how long have these symptoms persisted. So that's kind of how diagnosis goes in general. Again, as we get into specific disorders, I'll give you more clear-cut examples of what those symptom categories look like, how many of each symptom you have to kind of meet before you can be diagnosed with a particular disorder. Okay, I told you that was short. Any questions about assessment and diagnosis?